Thank you very much for this introduction. Well, the purpose of my talk today is about the use of Bayesian network in order to understand in prostate cancer interpretation of result from screening, and also to develop a new model for screening and early diagnosis of this disease. The field of my research are predictive oncology. I use for that data generated or collected from clinical, pathological, radiological, or genomics source, in order to discover new relevant marker for diagnosis or prognosis or diagnostic of prostate cancer. But we use also model using knowledge, current knowledge about prostate cancer, in order to provide a model to solve a problem, in order to provide decision support and information for clinician or for a patient. So the outline of my talk today will be, first of all, a short introduction about the prostate cancer and the marker, prostate-specific antigen. Then we see a result of current study on screening of prostate cancer and the problem of misinterpretation and difficulties in terms of interpretation of this study. Then I share with you, before the conclusion, some application from my group of research using a Bayesian network in this axis. First of all, prostate cancer is a health problem around the world, mainly in North America or Europe, that risk to be diagnosed with a prostate cancer during the life is about 15% for men, and the risk to die from a prostate cancer is about 1.5%. In France, one man dies from prostate cancer each hour. The mean age at the diagnosis of prostate cancer is about 65 years. Since 1980, a new marker was introduced, said in clinic. It was a discovery by Wang, and this marker is prostate-specific antigen. And you can see that from this discovery and its introduction for the practice, the number of prostate cancer, the graph on the right, increase dramatically, and also the mortality of prostate cancer decrease slowly. But prostate cancer change the face of prostate-specific antigen change the face of prostate cancer for the best, because the mortality decrease, but also the worst because diagnosis of prostate cancer using PESA increase over treatment, and for men save to prostate cancer, about 20 men are over-treated with alteration of quality of life, sexual or urinary quality of life, without the benefit in terms of survival. Why? Because prostate-specific antigen is a marker of prostatic tissue. It is not a marker of a specific prostatic disease. It's not specific from benign disease of the prostate or cancer of the prostate. For symptom of prostate, we have the same warning thing: low urinary tract, example, or ways of prostate-specific antigen in the blood. Like other marker, say in clinic, is defined by the Bayes theory, usually for screening or early diagnosis. We use a cutoff for, and the accuracy of this marker is defined by sensitivity and specificity. And this is used to define the positive predictive value. It's a probability to have prostate cancer if the test BayesiaLab is positive. And you can see in this theorem that you have the prior probability, the prevalence is the frequency of the disease in the population, and the other term is the accuracy of prostate-specific antigen test with false or true positive or true or false positive test. So prostate-specific antigen performance are not so good. You can see here the distribution in a normal population of prostate-specific antigen level in the blood. And you can see if you use a cutoff between 2 or 4, that the positive predictive value, the probability to find with biopsy of the prostate cancer is only between 5 to 10%. So, for the last 40 years, many studies have been performed in order to evaluate the utility, the benefit of prostate cancer screening using a prostate-specific antigen. For health authority, only randomized studies are used or recognized to provide the guidelines. Real data from the real world also be used, for example, in case control study, but they are not so well considered because they can have a selection bias or interaction with a confounding factor. But if you want to assess the benefit of prostate cancer screening using a BayesiaLab, you can this graph, this causal graph, introducing risk factors of age, genetics, for example, ethnicity or familial history, or now genetic marker. Obviously, the test, prostate-specific antigen, and the target, which is the diagnosis of prostate cancer on biopsy, but recently surrogate endpoints such as lesion on also from the diagnosis. You need to evaluate the outcome of the disease, and mortality of the disease. This type of assessment could be also described in this table according to the Pearl approach. It's a heuristic system because we want to solve the question: the screening, is it effective for prevent death from prostate cancer, for example, and this could be made by randomized trial or causal Bayesian network. We bring close also Kahneman hierarchic system in terms of psychological approach, because we see that the interpretation of the result are not so easy, and misjudgment or misinterpretation of the result are easy to make. So what are the results from the main study on the prostate cancer screening, but also controversies and fallacies from this study? You have two main studies, randomized study on the screening of prostate cancer and mortality. So the first one is a US study with no benefit of the screening between the control and the group with the prostate cancer screening in terms of mortality and metastasis outcome. Other study was an European study. It's a positive study with a relative reduction of prostate cancer metastasis, about 50%, and reduction of mortality by prostate cancer, about 37%. So this different results introduce debate, and this debate took place between supporter of screening with decrease of metastatic stage, decrease of mortality, decrease of health costs, but on the other hand, opponent who said that prostate-specific early diagnosis introduce over-diagnosis, mainly a biopsy, with a few positive biopsy, over-treatment, and decrease of quality of life after the treatment, mainly sexual function or urinary function. But health authority chose to support not recommendation for PSA screening for men, mainly in the general population without a symptom. But 20 years after, the US study have been questioned because control population have been contaminated by PSA testing apart the study or outside of the study by the man in the control group, explaining that this study was negative. Moreover, the real world data shows that since the no recommendation of PSA screening by health authority in the US, Europe, or in France, for example, induce an increase of diagnosis of metastatic disease, and obviously less early disease, which could be easy treated. Metastatic disease is for a patient difficult situation because it needs heavy treatment, such as chemotherapy, for example, and few of these metastatic disease could be cured, and the death is usually the outcome of metastatic disease. After that, expert report guideline also give us 3 other recommendations about screening and prevention of prostate cancer. But the guideline override causal reasoning. Why? The first one is not recommendation of PSA screening in a symptomatic man with low urinary tract symptom. The second is not recommendation of PSA screening for men with high risk of the disease, such as patients with a family history of prostate cancer. And the third one is limitation and warning for the use of treatment of benign prostatasia in terms of prostate cancer. Said that this drug can increase the risk of aggressive prostate cancer. If you look for this recommendation, but some of them are the survival of Bergson selection bias. This bias has been formalized by Bergson in 1946, but this bias is present in medical publication, and you can see warning in Nature Communication during the pandemic COVID period, with the increase of publication with this type of, in terms of prostate cancer. The fact to say that prostate cancer is not recommended for asymptomatic, no symptomatic man was followed by a recommendation to use a prostate-specific antigen for a symptomatic man. But as you can see here, and it is widely that the prostatic volume in benign prostate hyperplasia induce increase of PSA, increase symptom. And if you use a prostatic specific antigen for a symptomatic man, is the worst situation to predict prostate cancer. The performance, the accuracy of PSA, the positive predictive value is better for men with no symptom of prostate cancer. Then the second recommendation was to not recommend screening for men with a high risk of the disease. But if you have a risk factor, genetic risk factor, for example, you increase the positive predictive value of a prostatic specific antigen. And after this recommendation, the recent publication shows that despite the contamination bias in the US study on screening, we have a benefit using the screening if the men have a family history of prostate cancer with a reduction of about 50% of the mortality by prostate cancer. It is clear that in this situation, the increase of risk with a causal factor increase the prevalence of the disease and increase the predictive value of the test, here, prostatic specific testing. The third situation is the use of drug, 5-alpha reductase inhibitors. These drugs are used to reduce the volume of the prostate in benign prostate hyperplasia. And they have been suggested to be prevention for prostate cancer because they decrease the level of androgen. But after this result, you can see that we have a reduction of prostate cancer, but an increase of the more aggressive disease defined by classification of the prostate cancer at the diagnosis. So health authority says that you have a risk to increase aggressiveness of prostate cancer if you use this type of drug. But 5-alpha reductase inhibitors, such as the finasteride, change also the accuracy of prostate-specific antigens. They increase the sensitivity of the test, and mainly for the aggressive disease, for the pattern of aggressive disease. So you have this situation, this Will Rogers situation, where 5-alpha reductase change prostatic specific performance and change also the classification of the disease. You have a migration of the stage if you use 5-alpha reductase inhibitor. And in this situation, you have an artificial increase of prostate cancer risk and aggressive prostate cancer risk frequency. Finally, 20 years later, the cohort of men treated and not treated by 5-alpha reductase inhibitor in the randomized study shows that you have a reduction of the risk to death from prostate cancer if you use 5-alpha reductase inhibitor. So, after these controversies and fallacies, misinterpretation of the study, we move to your contribution for screening and early diagnosis for using prostate-specific antigen. It is possible to construct a graph Bayesian network introducing a risk factor, age, genetics, the target, the test, prostate-specific antigen, but also modulator of prostate-specific antigen. See that. Androgen deficiency, for example, the use of as inhibitor, but also intrinsic genetic of prostatic specific antigen. We see also confounding factor in this model. In order to clarify, it is easy to define the factor which increase prostate cancer prevalence, prostate cancer, and we have other factors which change the accuracy of the prostatic specific antigen test. For that, we have introduced also in your data a genetic marker, and we have also used a confounding factor reported in the literature. Just a few words about the genetic marker are genetic variations. The combination of this genetic marker provide increase or decrease of susceptibility for a disease such as prostate cancer. They are easily used in the Bayesian network because you have only 3 possible status: homozygote, for example, AA, heterozygote, for example, AB, or heterozygote, for example, BB. For prostate cancer, currently about 50 to 100 genetic marker, which could be in the prostate cancer susceptibility. From that, we have used machine learning. In this field, we have tested 300,000 genetic variant with augmented Markov blanket model in order to define the more relevant marker to predict the risk of prostate cancer, and also on the other one, the other marker, the change in the prostate-specific antigen expression. This model also defines the relationship between the different markers, because if the genetic markers are close on the same chromosome, they are in a linkage disequilibrium, and in this situation, choose only one of the markers. These markers are redundant. So we have published some information about that in terms of risk of this marker, with or without a familial history, but it is also possible to infer the probability from the clinical data in order to predict the risk to find genetic predisposition and to perform sequencing. On the other hand, this genetic variant can also change the expression of the prostatic specific antigen in the cell. Genetic change explains the human variability for anthropometric biological marker. We identify 5 variants which able to change expression and the blood level of a prostatic specific antigen in men without prostate cancer. And if we introduce other parameters, we see here a genetic score, which is related to the level of prostatic specific antigen. Body mass index also can decrease the level of prostatic specific antigen, and also the volume of the prostate increase the level of BSA. So it is able to construct diagram, also in order to explore and to define if confounding factors are causal or not causal for cancer. If you look on the prostate cancer, you can see that some anthropometric factor discussed with the controversies. For example, body mass index have been reported as a risk factor for prostate cancer or aggressive prostate cancer, also the height. So we have developed a method to identify this type of biais. We use a two cohort of control with a low prostatic specific antigen. We define the first control, and another group defined by a negative biopsy of the prostate. If you perform case control study for prostate cancer, it is not ethical to perform prostatic biopsy for all men, and you need to use prostatic specific antigen. And in these two cohorts, here the control have low prostatic antigen, and in this cohort, the patient have high prostatic specific antigen, but negative biopsy. And if you compute the direct effect, you can see that the true causal factors such as familial history or genetic marker, which increase the prevalence of a prostatic antigen, it's genetic. You have the same trends, the same association in the two cohorts with the risk of prostate cancer. But if you have factor which induce modulation of prostate-specific antigen and induce a biais of selection, such as the prostatic volume or body mass index, you can see that the trends in the two graphs change. In volume, you have a decrease association, but this cohort an increase. And for body mass index, the same change between the two graphs. So on this slide, you can see that the patient stratified by age and prostate-specific antigen with positive and negative biopsy. You can see that the prostate-specific antigen is not very useful to stratify the population between a positive or negative biopsy outcome, and we have introduced in machine learning model with BayesiaLab the clinical data set, for example, familial history of prostate cancer or prostatic volume, and genetic marker which have been previously selected. And it is possible to construct an hybrid model with on one part the factors that increase the prevalence of the disease, and on the part the factors that change the accuracy of the prostate-specific antigens, such as prostatic volume or genetic. And you have here the size related to the mutual information with the target. So this model increase the accuracy. And from that, we have developed a simulator, web simulator with BayesiaLab, with different factors, age, family history, ethnicity, genetic mutation, prostatic volume, prostate-specific antigen, change in the androgen level, which also include obesity, for example. And from that, we have also introduced surrogate endpoints, such as the result of magnetic resonance imaging. And you have on this model that you can choose different factors in order to predict magnetic resonance imaging if you perform it, but also the risk to develop prostate cancer, to have the diagnosis of a prostate cancer on a biopsy. So to conclude, BayesiaLab and this type of application are powerful tool to explore data and to develop new model for personalized cutoff for markers such as a prostatic specific antigen. It can be evaluated by body mass index, by prostatic volume, by genetics. Also to integrate different ethics in order to drive decision making. This tool could be used in research, in education, because from the simulator you can simulate cases for students at medical school, and also provide information for the patient. So thank you very much for your attention. I hope perhaps you have some question.